This is Dr. Kachikian from the Black Hills Regional Eye Institute, and this is a case of a 5-year-old boy. Basically, he's a 5-year-old autistic boy who developed bilateral cataracts and was unable to really navigate and see. Then he had some trouble getting some care because of his autism. And so he was referred to me to see if we could assess his eyes, given the limitations, and then potentially remove his cataracts. And on exam, he was found to have these severe, really they were nuclear cataracts, even though their appearance is more cortical. Um, they were central within the nucleus. And you can see him there. There's just a central dense white cataract that was limiting his vision, just right over the pupillary area. And then the more cortical changes are noted in the periphery. And so we plan to do bilateral same-day cataract surgery for this boy just to get the cataracts removed and start him on his recovery and visual rehabilitation. So we start by making a side port incision, and then our main incision is 2.4 millimeters. And as you can see, the red reflex is somewhat poor, and so we're going to stain with trypan blue. A special thank you, by the way, to Dr. Jerry Barry and Peter Ness in Albany, New York, for their help. I don't do a lot of pediatric cases, and they are two pediatric ophthalmologists who were extremely helpful in coming up with the planning for this young boy. So we're going to stain with trypan blue, and usually what I will do is paint the surface of the lens with the cannula. I find that gives the best staining, and I don't really like placing the trypan blue in without any endothelial protection. I do think there's some day one postoperative corneal swelling that occurs when I do that. I don't know if it's any long-term issues, but in the short term, I think on day one, there's a little more swelling, and you could place the trypan blue under an air bubble, but I don't really feel like that gives sufficient staining either, and sometimes the air won't stay in, and so I usually just paint the trypan under the viscoelastic and then reinflate with viscoelastic. And I'm starting with a cystosome basically because it's a young patient. Usually I will begin and complete the capsulorhexis with Utratus, but in this young patient I did not want to have any difficulty puncturing the anterior capsule. And as you see, as I start this capsulorhexis, again, young patient, the capsulorhexis, if we do it traditional way in a more tangential pulling, the capsule will want to spiral out. So you do have to pull more centrally to keep the capsulorhexis the appropriate size, not too big, not too small. And it's this kind of combination of both tangential pulling and some kind of centrifugal and centripetal pulling to try and get the capsulorhexis an appropriate size. And you find as I do the posterior capsulorhexis, when I create that, it's a similar scenario and actually somewhat more difficult to even to navigate. But just gently bring the capsule around. There's obviously no rushing in these cases. In these cases, the patient is asleep under general anesthetic. And like I said, we're going to get both eyes done here. And we've got a nice view and create a nice round capsulorhexis, just kind of pulling centrally here at the end to round it off. The removal of the cataract itself is pretty routine. It's going to be soft because it is a pediatric case. So we'll do our hydrodissection maybe some hydro delineation, but then the lens itself should be relatively soft, even though it's white. It's not like your typical adult white cataract. So we'll go in just with the IA and maybe sometimes use a second instrument to help get some of the bigger pieces into the IA if necessary. But in this case, as you can see, most of the cataract just kind of comes out of the bag, and this would be typical for a pediatric case. The lens just comes out in one piece. So as usual, we'll go around and do our cortical removal, and this is kind of epinuclear material. Get that all out. Perfect. And usually I will do a little bit of polishing of the posterior capsule, either with the IA handpiece or with some BSS to remove any fibers that remain. And the next step is going to be that posterior capsular excess, and I am going to try and stain a little bit of that posterior capsule with some trypan blue. That was not terribly successful, but worth an attempt to get some good visualization. So we'll rinse out the trypan blue, inflate with some Provisc. There we go. And you can always kind of polish the posterior portion of the anterior capsule. Because we like to remove all of the residual epithelial cells. And you can see those coming off, and I think that will aid in minimizing any capsular phimosis over the long term. And then the next step is going to be creating our posterior capsular opening. And what we're going to do is place Provisc on a 27 gauge needle and first use that to puncture the posterior capsule, and then use the Provisc to push back. I'm sorry, it's Visco rather than Provisc. The Visco to push back the vitreous and the anterior hyaloid face. And as you can see, as we do that, we create an opening in the posterior capsule. It's not exactly easy to see because of the air bubbles and because it is somewhat difficult to create a flap. If you look closely, you can see now there's a posterior capsular opening. We will get those air bubbles out of the way, focus down a little bit, and you can see the elliptical opening there. We'll use the Utrata forceps and try and get a flap. Put a little more viscoelastic in to dampen out any vitreous coming forward. And again, because this is a younger patient, it's difficult to control exactly how the posterior capsule is going to tear. And the last thing you want is to have a large posterior capsular opening, which is going to prevent you from placing a lens in the capsular bag. because in a young patient like this, I'd really rather not, although it's not the worst thing, I'd rather not have a sulcus lens. So you can see a little flap, just trying to get the edge and avoid grasping vitreous, and also avoid allowing the capsular rhexis to tear out into the periphery. So again, we'll try our tangential and centripetal pulling. And I would have liked this capsular rhexis, posterior capsular rhexis, to be a little bit larger. Because of the elasticity, it's hard to exactly judge what the size is going to be when you're done. It's not like an adult where the size the capsular rhexis appears is the size the capsular rhexis is going to be. In any event, we've got our posterior capsular rhexis there. We didn't disrupt any vitreous. It should be large enough to not close for a while, although it may have to be enlarged at some point in the future. And then we'll reinflate our capsular bag and work on placing our lens. Now, for a 5-year-old, there is a chart that you can use. You want to leave some hyperopia so that as the eye grows, the patient doesn't become overly myopic. And there is a chart that Dr. Ness from upstate New York sent to me to allow me to calculate the appropriate lens after having measurements. So we'll get the lens prepared, and you just want to be careful when you're placing the capsular bag. Don't place it through that opening there. And as you can see, this is a Clarion lens, and it comes out with that haptic straight out. So you want to get that haptic bent right away. And then get it into the fornix of the bag. And what we're going to do is place it more in the anterior chamber and then position it so that we don't place it too deep and then have it be in the vitreous. So we'll use a Sinskey hook, get the elbow placed in the fornix there. Again, the nice thing about the elasticity of the capsule in pediatric patients is that the lens will stretch right through it. The capsule will stretch to allow the lens in. Then we'll get this elbow into the fornix as well. Perfect. And we can kind of rotate a little bit just to make sure that it's positioned appropriately. All right, so now we've got the lens positioned nicely within the capsule. We've got a posterior capsular opening. We will do our cleanup. I'm not too concerned about any residual viscoelastic behind the lens because of that posterior capsular opening. If there's residual viscoelastic behind the lens and there's no posterior capsular opening, there's only one place for that visco to go. It's either going to get trapped behind the lens or it's going to get carried into the angle. If you've got a posterior capsular opening and you've got some viscoelastic behind the lens, then that viscoelastic can make its way into the vitreous cavity, and that's fine. That's not going to lead to acute pressure spike. I mean, it might raise the pressure higher for longer, but the point is that the viscoelastic has another place to go. It can move posteriorly in addition to anteriorly. So you can see our posterior capsular opening. There's a little air bubble behind the lens. So you can get some of that out of there. And then the very last part is going to be suturing the incisions. And in this patient, there's a couple of things to keep in mind. One, he's a 5-year-old. So as I learned, the younger patients have very low ocular rigidity, so their incisions don't seal like adult incisions would, even if they're well created. This goes for both the main incision and the side port. So we'll hydrate them, but they both need to be sutured. In addition, it's going to be unlikely that we're going to be able to remove the sutures in a 5-year-old patient at the slit lamp. And so we'll use tenovicryl, which should be last long enough to allow the incisions to heal and also provide some stability. I'm going to use some triamcinolone just to make sure that there's no vitreous. It doesn't appear that there is. It seems like we're able to avoid any vitreous, but you always want to check, because the last thing you want to find at a day 1 post-op is a peaked or irregular pupil and vitreous to a wound. You can get a good view now of the anterior and posterior capsular opening as well. Speaking of that posterior capsular opening, one other option that you have, of course, would be to finish the case and then do a posterior vitrectomy and posterior capsulotomy using the vitrector. Go about 3 millimeters back from the limbus after you have placed the lens, and then use the vitrector to both create the posterior capsulotomy and prevent any vitreous from coming forward that way. So that's a reasonable thing to do. You do that as an extra incision, and you're disrupting the vitreous cavity a little bit more. So I elected to do it anteriorly, but that would be another option as well. So we'll seal our incisions, put a tiny bit of moxifloxacin in as well. I try not to overdo that. You don't want to have too high a concentration of that in the anterior chamber. And then we'll use our tenovicryl. Tenovicryl is a little bit difficult to manage. It's got some memory to it, more like kind of like a proline type of stitch, or a Merceline. If you've ever used Merceline, it gets kind of coiled very easily. So tenovicryl is the same way, but it's a very good option because it's going to dissolve and it's not going to allow the wounds to leak early on at all. Usually I will just put a one single throw in each incision, and that's what we do here. Some physicians would like to use a double throw to make sure that the suture is robust, that the suturing is robust enough to prevent opening from any eye rubbing. But the wounds are well constructed, and I do think that this patient will be just fine with a single interrupted stitch in each incision. I don't do a lot of suturing with tenovicryl. And it can be difficult to see at times, so it helps to lay it across the cornea. And try not to over tighten, just appropriate knot tension and IOP management. Then try and get it to bury so that we don't have a little kid rubbing his eye because there's a loose stitch. With vicryls, sometimes it acts more like a monofilament, so you can tend to leave the tails a little bit longer as long as it will bury. There we go. And we'll do the same thing for the side port. And really, as soon as this case was completed, we repeated the exact same procedure on the contralateral eye, and both eyes went very smoothly, and this patient had a excellent post-operative result. Again, it's just the visual rehabilitation that's going to take most of the time, getting him in glasses, making sure he wears his glasses, so on and so forth. Tie these knots in a typical 3-1-1 pattern. Again, not too tight. Occasionally, I might use vicryl sutures in transplant patients, or post-transplant cataract surgery patients that I might not be seeing back, and I don't know if I'm going to be able to take out a nylon stitch. So the vicryl does work well for those cases, patients who, if they live in a remote area, you might not be seeing them back very soon, or potentially ever, depending on where they live. And so they're not going to have the opportunity to have a suture removed. So vicryl is good for those patients as well, if you feel like they're going to need some suturing of their cataract incisions. There I'm trying to pull the conch up over the knot to allow it to bury, so that again, the patient's not rubbing their eye. The eye's a little soft, but that should be okay. Check our incisions. Looks really good. Anterior and posterior capsular opening look great. And that's our case. Thanks very much for watching.